And now I'm really delighted to welcome Mary Frances McMullin and Megan Laird, who are going to talk about what is wanted in a consultation patient-doctor, doctor-patient. Welcome.
Thank you, Nona. So, Claire referred to the landmark study. In the landmark study, it was quite interesting that what the patient and what the physician and their treatment goals were really quite different in some occasions. Whether it's reduction in symptoms, progression, the goals, what the doctor thinks they want and what they're doing and what the patient is looking at are quite different. So Claire challenged me, and it's her fault. Yeah, I like a challenge, to think about what the doctor wants from the consultation. So I've had a think about this, and I'm going to bring out some points of what I think I'm doing when I have the consultation, or what I want to achieve as the doctor, starting with the initial consultation, and then Megan's going to tell us what the patient wants from the consultation, and I think we might find they're not quite the same. So as the doctor, you start with the initial consultation. This is somebody who has been referred to the clinic, all sorts of different reasons. It may be their GP sent them, there may be something there. New patient coming with to the clinic, of whom I have never met before, and I have minimum information of what they're. So how do we go about this? So the first thing is you've got to introduce yourself. And you've got to introduce yourself in such a way that you immediately establish what you're there for and what your professional role is. You know, you don't want to know that I'm Mary the hairdresser. I'm actually there as Dr. McMullin to give you an opinion. So that first 2 minutes is actually very, very important. Personally, I try to go and get people out of the outpatient clinic where they're sitting and bring them around myself and introduce myself on the way around. Do that for various reasons. One, it's an excuse not to have to sit all day long. Go for a little walk. I think it is quite nice, if possible, to bring the patient around yourself. It's also quite useful because all the other people in the outpatients can see you coming in and out, so you know you're actually doing some work. But because otherwise they're sitting there going, nobody's paying any attention to us, you know. So that's quite useful. Then you get in, and the initial thing is really important. You know, what's the problem? Why are you here? So this is actually fraught with difficulty for all doctors, because the question that's often asked is, what brought you to the hospital? And of course you get the answer you looked for. The usual one you get actually is a junior doctor, the ambulance doctor. So you've got to phrase this question that it makes sense at that. I will always want to know at this point, did you know you had been referred? Because this to me is actually very important. People are referred because their blood count is abnormal. Sometimes they know about it, and that has implications as well, because they've looked up the internet, and I've once had a patient who wrote their will before coming to see me, which was, you know, and hadn't even seen them. But other people have no idea, and they have turned up, sat outside in this outpatients with all these people who belong to all sorts of different clinics, and by the time they get in to see me, they're terrified. So I think that if somebody is referred to hospital, it is the duty of the referring person to explain to them that they have been referred because their X is a little bit high. We just need to go into further to investigate this. But it amazes me how often people turn up because they got a letter and they had no idea. And then we get to sort of showing what goes on, who are the personnel and what do they do. It's not just me, there are people like nurse specialists, and you've got to sort of bring all them into it. So that initial meeting, I want to establish the problem, which I'm coming to, but also to set up a clear professional relationship with the patient. Sorry. So that's the initial consultation. Then we have the problem. What is it? And that's what you're there for, to find out exactly what's going on and trying, as I'll come, to arrive at a diagnosis. So absolutely crucial then is the history and examination, particularly the history. This is actually quite boring for people because you've told your story umpteen times, but doctors have a very clear way where they are trained to go in all directions and pick up all points in the history. So all those silly questions actually have purpose. And they're also very good screening, that you don't miss things if you go through a systematic history. Examination, the same. And then, of course, we get to the tests to actually try to find out what's wrong. If it's, as with MPN, we're often talking about an abnormal blood test, the first thing you got to do is do it again and see if it actually is abnormal. And then on to nasty tests, like things like bone marrow, aspirate, and trophine to investigate this further. So there's lots of tests have to be done. Bone marrow, aspirate, and trophine, I'm sure some of you have had that and probably not experience you want to repeat unless you have to. It's not very nice. So there's a whole issue about how you do that, how do you introduce it. If it's an outpatient, you may be giving people information, sending them for the test. I have to say, when I trotted around the hospital doing all the bone marrows many years ago, we used to try not to tell people we were doing the test until we were there to do it. So they didn't actually have to spend their time worrying about what we were going to do. That's probably not the politically correct way to do it now, but the argument was that if you didn't, you need a bone marrow test, and by the way, I'm doing it now, I'm getting it done, but it doesn't always work like that. So we then end up with all this history and examination. Hopefully, we end up with a diagnosis, and that's really sort of the object of what we're trying to get. Here's a problem, let's make a diagnosis. So these are the diagnosis. Has a number of criteria. These are the most recent ones for polycythemia vera, just to give you an example, where you need an elevated hemoglobin, a JAK2 mutation, and you may, if you follow the WHO criteria, need the results of the bone marrow test as well. But that's what I, as the doctor, want at the end of putting the problem together and coming up with a diagnosis. And I make this point because doctors, on the whole, generalizations I know are not good, but on the whole, are really problem-solving scientists, I put it, that they're trained to look at an issue, see what it is, put it together as a diagnosis to come up with a solution. So they will think, on the whole, in that quite concrete, and obviously I'm generalizing, some people are better at going in other directions, but the focus from the beginning is to sort of try to get to a solution for the problem, which is called a diagnosis. And then we get to the next bit that is, I could have given the whole talk on this, is what you do next and how you move on from that and what doctors want to do. So I've put it as explain the diagnosis, prognosis, and treatment. That's what you want to do. You've got to tell people what they've got. You've got to tell them what's likely to happen to them, what complications can arise, how it can be treated, because that's what the patient wants to know. And I have to say, it's compulsory to inform not just the diagnosis, what the complications, and what I put it as the good and the bad. So, it's great to say this is, I can treat this and you will live for normal lifespan or whatever, but you've got to actually be able to say, actually, there's 10% chance of this over time, and, hear that. And that is a big problem because it's a big, different group of patients. So you have everything from somebody who's looked it all up on the internet and is actually way ahead to somebody who hasn't any idea and come across medical services. So this is all about communication, and it's actually the crux of the whole interview. It's probably, with a new patient, the second interview. And how do you do that and what do you do? And I don't have the answer to this, but I'm just going to give you some of the things that are involved. So obviously the first thing is oral communication. I'm going to sit and talk and try and explain this. I have to say, I will also, I'm still writing the notes, write a note that I've done this and that I have explained, and I've explained the likely complications. So it's written down so that you can't tell me in 10 years I didn't tell you, because it's there. We also have an obligation now, it's absolute requirement to give written information. This is often quite difficult if it's the first thing, because somebody shoves this book in your face and says, you know, you've got to take that and read it as well. You may not read it then, but you know, you should have written information. And MPN Voice really come into their own here. Somebody was saying last night, it was amazing that actually very often the written information, the NHS doesn't supply it. It's been by the various societies, and you know, we really, really want things like the MPN Voice booklets to give to people. I think people will also, and you have to realise this, will look it up on the internet. You know, there's no point in saying don't look it up on the internet in this day and age. Everybody's done it. But I suppose what I would be trying to do is directed them to things like MPN Voice. You know, it's trying to get people to the reliable things, because otherwise the internet's a scary place. What else should you do as a patient? Should you record this? Possibly, because there is a problem. You know, once you start this conversation, I know what I'm saying, but what do you hear? And, you know, it's never ceased to amaze me over the years what patients have told me that I have said. And I know I haven't said that, because I know I would never say. That's not to say that they didn't hear that, but, you know, what you say and what you hear are not necessarily the same. And particularly if it's a new diagnosis and it's really frightening. So should you record it? Some people do. We can have a discussion on that. I hate being recorded because I hate the sound of my own voice if somebody plays it back to me. But, you know, it's one thing to think about. But then you don't want to get to the stage where I'll do this all on a wee video and hand it to you, and I don't have to do it anymore. You know, you do want the doctor in front of you explaining it. I have one lady, this always fascinates me. I have one lady who comes in and writes down everything. She's very good at shorthand, and she writes down everything I say in shorthand. I'm absolutely fine with that, because I can see what they're doing. You don't want somebody recording you and not telling you they were doing it, but you know, if I can see it. And she says that she finds it really useful because she does fast shorthand, and she can go back and look at it and see. So there's a whole issue about how you get the record. As I say, the GP gets written information, and the things I would very much say, I don't want to have to tell you this and then tell your partner all over again. So really bringing somebody with you is really useful. And I know with COVID, there was all sorts of problems of not letting people in, but certainly in our trust, we've said, no, you have to have somebody with them, let them in. And written lists of questions, really good. If you've, you know, lots of questions, because you forget when people go, I'm very happy to see written lists of questions. I would say, listen to me first, because quite often we've covered the questions, and you know, for repeat appointments, written lists, the things that concern you, writing it down is really helpful. So the next thing we get is that, and you might have said, you should have got to this quicker, is in this consultation, should you have empathy with the patient? Well, of course, we're doctors, we're there to want to do it. That's what we want to do. But it is, you know, it may not be quite what you think is empathy. But I hope you've got some insight into the disease, understanding and active listening. But I haven't got the disease. Thankfully, you've got the disease. So, you know, you've got to take that into consideration and explain. Then we get to what we're actually going to do in this consultation. And what doctors want to do is solve the problem and heal the problem. I'm going to say the cure word, which doesn't mention, but, you know, ideally, we would like to cure the patient of whatever it is. Often we don't have the cure, but we're certainly looking at treatment to prolong life or prevent progression. And I looked up on the internet a picture of healers. That was a very interesting experience in Google Images. That was the best I came up with, this lady who's the healer. But, you know, you have to think what we think we want to do. And, we want to solve the problem. We want to heal as well. So we get to the treatment. And again, doctors are very keen to say, this is what we do for this. This is what we're doing. We're offering treatment. We can talk about the sort of watch and wait cases. That's actually as difficult for the doctors as it is for the patient, because they like to go and this is what we're doing for this. But how is treatment success measured? And that's also interesting because, again, we're scientists, we're quite concrete thinkers. So we like the numbers to get better. It's very easy to see, we've given this and here's the numbers better. If they have signs, this is supposed to be a picture of somebody with an enlarged spleen. And you can see the spleen getting smaller, because that's great. You're all going to say to me, what about the symptoms? And Claire's talked about this already. And that's more difficult. We've looked at this, measuring them, and the idea of this is the MPN 10 as well on the bottom. Can you see an improvement in the symptoms? But my nurse, when she's here, said the doctors don't listen enough about that. But the reason they don't listen enough is because you haven't got the answer to the same extent. But they should be thinking about the symptoms as well. So that's sort of the whole process, you hope. I'm just in the last couple of minutes going to dwell on a couple of things. And this is a slide from my colleague Karen Kerr, who unfortunately is unwell at the moment, of her description of the doctors and a follow-up appointment. And I think this is actually, it does make fun of me a little bit, but that's okay, because it really does sum up what you're doing going forward. What you've got, you've another appointment, you've got this patient, and as she says, you've got 10 minutes to sort it out. And I'll come to time in the next slide. So they want to see the blood counts, they want to see what dosage people are taking, they want to know, they might listen about side effects if you're lucky. And then obviously any new problems or issues, and as she put it, new script, new appointment, date, job done. So it is really clearly follow up. You're trying to follow this up, sort it out. And again, I would make the point, we'll look at the numbers. Have we achieved what we're sort of starting to do? So you can get at me about that. I'm not showing you the second slide where she says what she does, where she's much better at listening to the person. But that's the reality of what you're trying to do. The next point I wanted to make was time, and I think this is very important because it does dominate a lot in consultations. So I want to do the clinic, I want to sort everybody's problem out, but I don't want to be there at 7 o'clock. It's an afternoon clinic, I think. And you don't either. You don't want to be the last patient when I've sitting at 7 o'clock because I haven't seen all the others yet. So time really dominates this process as well. You have to be careful that things are moving, that we're not getting further and further behind. And there's never enough time. Everything I've ever done, there's never enough time. But just to sort of think of it in context, I would have 15 to 25 patients in a clinic. I can see, because I know this, 15 patients reasonably comfortably, because I've been doing it for 30 years, so I know. I need somebody who's going, if I'm 25, there needs to be some other people as well. But there's lots of issues within this. I would contend that second appointment, when you're explaining the diagnosis, needs extra time. The managers always count new patients, but actually it's when you've the big appointment where you tell them all about it. There's always the unexpected where somebody comes in with some awful problem that you've got to sort out. So time sort of dominates this, and you have to give, and that is not a reason for not taking some of your doctor's time. I hate it when people come in and say, oh, you're too busy. No, I'm not too busy. I will do it. But you can't have the whole 3 hours for yourself, or you can only have it when there's some unbelievable problem that I have to sort out. So time always is there in the background and what doctors have to do in consultations. The other thing doctors want is patients in trials. And I think this is actually quite important. Now, putting patients into trials in a clinic actually takes more time and is more work, but we would see patients in trials is extremely important. We get newer treatments sooner, we get better treatments, we stop the development of ineffective treatment, and we do other things like increasing knowledge and understanding of the disease. So again, if you have that mind of a problem-solving scientist, then you want trials to try and improve things. So that's Mithridate in the corner, which is one of the trials that we have coming up. And Mithridate's the magic elixir. And of course, we all want the magic elixir to sort the problem. But also, I put a plug for Mosaic there, which is my own study, which is an epidemiological study. But it's, again, very important to look at causes of disease that we understand further in the disease. So doctors really want clinical trials. And then this is my last slide. So then I thought, what else do we want to do in consultations? And there were a few things. I actually think teaching staff and students is really important, because if we don't get to teach other people, then where do we go in the future? At the end of the day, we want satisfied patients. You know, we want people to be happy, maybe not happy because they've got this, but at least that they're satisfied that they've been listened to and attempt made to manage the situation. And of course, we all also have to earn a living. There's one. You have to remember that, you know, it is your job at the end of the day. So that's my thoughts. Thank you very much. I'm going to hand over to Megan to say something completely different.
Okay, perfect. Hello there. My name is Megan Laird, and I'm an essential thrombocythemia patient. A little bit of background about me, just so you know a little bit more as to where I'm coming from. So I was diagnosed with ET back in October of 2017. So I've lived with an MPN for just over 5 years now. I've actually attended 3 different hospitals now for monitoring of my MPN. When I was first diagnosed by Prof. McMullin, I was in Belfast City Hospital, obviously, and then I returned to university and was monitored between Belfast and Leicester. And then now, after I got my grad job, I'm now monitored by Prof. Harrison's team in Guy's and St Thomas in London. So I think this is probably quite good at me giving sort of a different perspective of a patient in 3 different sort of clinical centres. I've had quite different experiences in all of them, in a good way. So I think I can give a bit more of a rounded sort of perspective on it. So the first thing I thought I would just lightly touch on is just sort of the impact of COVID-19 on consultations that I've noticed as a patient. So I'm sure obviously everyone knows COVID's been a very big part of everyone's lives for the last couple of years, and nowhere more so in a hospital setting. So at the beginning, I, like many in this room, was shielding. And I actually really appreciated not having to go to the hospital, because I was super anxious about COVID. Everything was so uncertain. We didn't know what was going to happen to us. So the consultation on the telephone really, really helped me in that sense. And then as my sort of anxiety decreased with COVID, which was for the better, thank God, I've personally started to see the switch back to in-person consultations with myself. And I must admit, personally, I do prefer the in-person consultation. It does make it sort of a day experience, but personally, I think having that sort of once every 3 months, I would rather have an in-person consultation. Sort of gives a bit more sort of empathy with the consultant when you can see their face and see how they're saying something, not just the way you hear it, as sort of Mary Frances touched on. But also, just in relation to that, obviously PPE does then come into appointments, and I noticed personally that even though I'm quite young, some would say, I find it sometimes a bit difficult to hear somebody speaking in a mask. I do understand that it's completely compulsory in medical settings, but I know certainly if you're sort of hard of hearing, that mask in a consultation, both for the patient and the consultant, can sometimes bring about some communication issues. So it's important to make sure that you're being clear to your consultant and your consultant is being clear to you. But obviously masks are compulsory, so we just have to get on with these things as much as possible. So moving on to, maybe not. Yeah, there we go. So Mary Frances touched a bit on the initial consultation. I thought I should too as well, because to think back, I sort of started thinking about this because it's such an integral day of your life. It's something you will never forget. Certainly I'll never forget it. Not because it was negative by any means. But it's the day that your life really does change, you know, and the impact of that certainly can't be understated. So I certainly went into it with a lot of questions. The first being who is this lady in front of me? Obviously, it was important to understand what Mary Frances did, what her team does. I had never known what haematology is. As much as my biology GCSE helped, it didn't help that much. So, you know, who are these people in front of me, and what is it? How do they have any relevance to what is wrong with me? Was quite important. So, also, it's important to note that certainly some of you might realize that you don't see the same consultant each time you go to a clinic. I've kind of had different experiences where I've always seen the same consultant in certain hospitals, and others where I've seen a different consultant every time. So it's important to understand sort of the team that's involved in your care, and also be reassured that the standard of your care doesn't drop just because you're seeing somebody else that day, which I've always been very reassured, no matter what hospital I was at, that that's the case. So moving on to what happens next was my sort of big question, and what symptoms am I going to get from this medication that's being spoken about? Moving on to why has this happened to me? As a young 19-year-old being diagnosed with this, I just sort of thought, why me though? This is really bizarre. A lot was quite unclear at the time. So the fourth one there is will. So it sounds a bit morbid, but will I die from this? Because the minute you hear cancer, you think possibly death. Possibly maybe my naivety as well at the age that I was. But also, will I pass this to my children, grandchildren at the age, obviously, I still don't have any children, but it's certainly something I see for myself, and it's something that I wanted to know sort of straight away. And also one thing that my mum and dad wanted to know was, do my siblings need to get tested? Is this genetic? Do we need to think about this? So then another question I had was, will this change into another MPN, which has been talked about quite a lot today. I do remember Mary Frances explaining the difference between incurable and terminal, because that was one of my other questions that I had. So it's really good to sort of be reassured in a consultation that your consultant sort of is a friendly face and actually really explains this difference. Because I know certainly when I say I have an incurable blood cancer, people look at me like I'm dying, which I certainly don't think is the case. And also being able to sort of explain that difference to family and friends in a sort of user-friendly way is really important to sort of get from your consultant. Then moving on to sort of how would this affect me? I think that's probably a big thing that everyone thinks of, especially at the first or second consultation. But honestly, I was actually very relieved to get a diagnosis in the end, which I'm sure a lot of patients also can relate to. But I do remember turning around to Mary Frances initially and saying, yeah, I've got a ski trip booked in 2 months' time. Can I still go on that? And Mary Frances looking at me as I had just come over from the Royal Hospital. I was being treated for a blood clot in the brain at the time. I'd been 2 weeks as an inpatient and I was let out for the day to come and see Mary Frances. And I think she looked at me thinking, you've got bigger fish to fry right now than bothering about your ski trip. Probably didn't help that I also asked, could I also do a skydive or a bungee jump in the future? I was told, let's treat the clots first, Megan, and we'll then maybe review this at your next appointment. I haven't done either yet, but I will. Consultants are very skilled at giving you all this information that you need and providing it sort of in a patient-friendly manner and using language that we understand, especially if you're not from a medical background. So, oh, go back one. Yes, okay. So when I sort of started thinking about this talk, I sort of thought, what's my journey when I know I have a consultation coming up or an appointment? What's the sort of journey through that? And I sort of feel there comes in sort of 3 stages. The first stage being at home and planning for the appointments. So I find, especially since I've moved now to 2 different hospitals, if you get an information pack initially, that can really help make you sort of not as worried about attending hospital, especially if it's a new hospital. And I always find that if it can maybe include an introduction to your consultation team, possibly who's involved in your care, maybe photographs. I definitely would appreciate that sort of thing as a patient, and a map of the hospital, just like laid out clearly what you could expect, maybe even a timeline of what happens in a consultation, how long you should realistically be at the hospital. I know it sometimes can vary, but so you know that you're not going to be there for 20 minutes. It might be a few hours, and so it's realistic of your expectations. I do think it would be ideal if all hospitals could sort of adopt the same approach to this information pack, which could maybe be something looked at in the future. When planning to attend, I always write a list of questions, which also Mary Frances touched on. I find that I get the worst brain fog ever. So if I've not written it down, I am absolutely not remembering it in those 10 minutes that I'm in the consultation. So I think there's 4 considerations really that I think of when I'm going to a consultation. The first being transport. So again, I've had 3 different experiences, starting from not having a car or a license to then having a car and a license. And now I get public transport because I'm based in Guy's and St Thomas. So I get the tube actually to all my consultations now. And these can all sort of give different variations of anxiety for a patient, to be honest. I know I worry about arriving and being extremely out of breath and sweaty sometimes, but also sometimes that can be unavoidable depending on where you attend. So in order to sort of assist me with, especially now, I use the Please Offer Me a Seat badge on the tube, which some of you may be aware of. It's free to get on the Transport for London website. And I find if you wear it sort of on your coat or your clothing, it's really helpful at someone offering you a seat before you have to ask, especially if you're an introvert. It can be difficult to make that first step to actually have the courage to ask for a seat, and I find people are very kind at offering. Again, this is a coping mechanism that makes my days at clinic a little bit less stressful, so I'm willing to do anything. You also have the Hidden Disability Sunflower lanyard, which is also great at assisting in times like this. So the second thing I always think about is parking. So I've been to a hospital where you have to pay for parking, and another where you're given a free parking voucher. So it's important to know sort of what to expect in the hospital you're going to. And it can also be quite difficult to find a car parking space at hospitals. It seems to be the one place where everyone brings their car to. So it can be a wee bit stressful, especially if that's the first thing that you're experiencing at the hospital. However, I find that since I've been granted a blue badge, I find this really decreases my anxiety in attending clinic. I'm not as worried that I'm going to arrive out of breath, and I should be able to park a wee bit closer. But you will find that in hospitals, even a blue badge space is hard to come across, to be honest with you. But just as a point to note, in case maybe you're unaware, but my 2 clinical nurse specialist teams that I've been under have assisted in the application of my blue badge and the renewal. And they're an amazing lifeline to providing sort of information and things that are services that are available to us as MPN patients that you maybe weren't aware that you could possibly be available to you. There's also quite a big stigma, I find, of having a blue badge. I still get dirty looks from people who look at me and think she looks so well, not in I'm fabulous way, but she looks well as a patient, not particularly sick. But I've really, to be honest, had to just get over the fact that there's actually no shame in asking for a bit of help. And if that makes my day a little bit easier, then why should I ever be ashamed to admit that I have one or use one and that it helps me in life? Cost is the third thing. So in London, obviously driving to appointments, you've got the congestion charge, you've got the ultra low emission zone, and also parking charges, which are a fortune. So you kind of have to weigh up the cost of public transport versus the cost benefit to the patients. But obviously sometimes the more convenient methods, such as a taxi, could be the most expensive method to get to an appointment. And then fourth, the time commitment, really. Sometimes, often, you have to take a day off work or a half day. So it's important, especially now that I work, it wasn't as much a factor when I was a student, but especially it's important now that you are honest with your employer and that they make reasonable adjustments, such as, days leave and that kind of thing to attend your appointments. Go on to stage 2. Yeah. So of course, when you arrive at the appointment, this is the second phase. So sometimes it can be very unfamiliar surroundings. So first of all, you might be already exhausted as you arrive, just getting ready to go to the appointments. Then you have to find the correct clinic and report to reception. I always find it's really helpful when you get eye contact at reception, and a friendly smile can really reassure you that not everyone's that scary in the hospital. Then you'll sit in the waiting area, and after observing patients in my last clinic, I noticed that everyone's sort of doing different things. You've got some people who are sleeping, some people who are reading, listening to music, some people are just quiet with their thoughts. And it's important to sort of allow patients to do their thing sort of in the waiting area, and maybe not impose on others if you feel that they're sort of quiet with themselves, and that's obviously all right too. So I do actually think it'd be quite helpful if there was a screen with all the staff on shift that day. I know I would personally appreciate it, including sort of clerical and medical staff. Just gives a wee bit more of a sort of human factor to the clinic. One thing I've always noticed is Belfast City Hospital has a young person's cancer waiting area, which is amazing, to be honest with you. And it definitely makes you feel less different, I suppose it is probably the key words. And it has sort of comfy seats and a television and board games, and makes clinic a little bit less clinical, which I personally really appreciate. I know it was funded by cancer charity, wasn't it? But I find it's brilliant. Something obviously that's changed since COVID sort of is your tea and coffee offering at clinics. I know I personally really appreciate a tea or a coffee anywhere I go. But obviously since COVID, it's maybe not as much on offer. But again, it just makes it slightly less of a clinical environment, maybe one a wee bit more sort of friendly. Part of me thinks that it could maybe be a good thing to maybe include an area in a clinic, if possible. An area sort of for patients to talk, and then a quiet area as well, because sometimes you look around a clinic and people are terrified. And I remember being that person looking around, and especially in Belfast, we're mixed in with oncology as well, and looking around and you see people who genuinely, who obviously look like cancer patients and are going through chemotherapy and, have wigs on or scarves and that kind of thing. And so it can be quite a daunting place, especially if you think, well, is that my future? So possibly to have a place where people feel that they can talk to each other, and they go there and they feel that you can approach someone and say, how's your day? And then an area where if you don't want to, that is totally okay as well, and a quiet area as well, if possible. I just think it's maybe a good suggestion to sort of give. Then obviously you have your blood test with the phlebotomy staff, which I always find are brilliant, because I always worry that they're not going to get my bloods because I've got quite bad veins. So it's always great to know that you're coming to a department where that is their complete specialty. And I've never once not been able to get bloods at a clinic, which is brilliant. In between all of this, in between sort of going back and forth to your bloods and your consultants and things, I think it's really important that staff in the clinic really reassure patients they've not been forgotten. You can see in clinics sometimes that someone's worried that they've been missed, or they've been sitting there longer than they did last time, or that kind of thing. And I've personally witnessed staff reassuring patients at all hospitals I've been at, and it really makes that difference. And just that little bit of communication where, your bloods are being processed, we haven't forgotten about you, get another sort of tea or coffee and we'll be with you within sort of the next hour. Something like that, it really makes a big difference. So then obviously you go into your consultation, and that's sort of your oral explanation as to what's happening with you at the moment. I always bring a list of questions, like I said, and try to walk away with more answers than questions, which is always a good thing. Early on, I always find it really beneficial to bring a companion, because I do tend to walk into a consultation and then 10 minutes later I've forgotten everything I was ever told. Never thought about recording it, though might try that next time. But nowadays, as I've had this for sort of 5 years now, I find I actually prefer to go alone, not as an insult to any of my family or friends, but I feel less of a burden if I'm doing it by myself, but also I feel like I've got this now. So it's one of those things that I like quite doing by myself. It's a day for me. I usually get a nice lunch afterwards and somewhere in London. And that's my little treat for having to be sort of poked and prodded in the hospital. Communication is obviously so important in your consultation. And it's important to sort of just note, is there any difference? Am I progressing? Am I getting worse? Am I getting better? And we just really, really want honesty as a patient. Mary Frances talked a little bit about the good and the bad. I'd rather know both. Tell me everything so then I can sort of make the sort of brain fog, the decision by myself on what I want to believe. And I find that the MPN 10 symptom burden is really helpful at sort of actually sitting down and asking myself, how do I feel differently to when I was last here, which is quite helpful. So then obviously you then go to the pharmacist. Ooh, back there. You go to the pharmacist. I've had, again, 3 different experiences in attending sort of pharmacy after a consultation. Sometimes you'll find that the consultant goes and gets the medication and brings it into the consultation room, which can obviously be less stressful. But sometimes I've honestly found that having to go and wait at a pharmacy in the hospital sometimes actually takes longer than my entire clinic did, just depending on what hospital you attend. To me, that's really stressful, I'm not gonna lie. I actually dread going to the pharmacy sometimes after a clinic because I've waited, as I said, sometimes 2 hours just to get my medication. And obviously when you're in sort of central London or in Belfast or something, once you're there, you may as well wait, there's no point coming back again. So sometimes it's just, you have to just sit and bear it. But I do find pharmacy actually a wee bit more stressful than clinic a lot of the time. And your consultant really is your point of contact, your first point of contact. They provide the intro and the intro also to the wider clinical team that you have at your disposal. And obviously I was introduced to my clinical nurse specialists in all my hospitals, and I've personally found them as an invaluable lifeline, especially in the early days when I had so many questions, to be honest. So moving on to the final stage. The third stage obviously is just getting home, which people sometimes can be a bit anxious about as well. So it's similar considerations to when you're getting to the hospital, how you're getting home, finding your car or finding that public transport station. Maybe if one's closed now and I have to take a different journey, can be a wee bit stressful. And ideally it's sort of avoiding the rush hour as well. I know a lot of patients prefer clinics in the morning if possible, but again, it's not always it's not always the option. And I always find that I'm exhausted after a clinic day, even though I don't do too much walking. It's just an exhausting experience, to be honest. I'm a bit more energetic than I normally am. I've had to talk a bit more than I normally do. And so it's sort of bringing in that sort of fatigue management to it and knowing maybe to have another day off work or to try and schedule a clinic on a Friday. So then I have a Saturday to recover. It's sort of just putting those provisions in place to sort of help you. And I always appreciate the follow-up letter that comes in the post after a clinic, because if you haven't quite got something in person, it's good to sort of see it all written down. I find that really, really is very helpful. So just to sort of summarize, a lot of knowledge obviously comes from your consultants and their team, and they can really help manage your expectations for your future whilst living with an MPN. Management of a chronic condition can be difficult at first, believe me. But it's important to sort of share coping techniques with your consultant as well, because they're the first person that'll then tell another patient. So then we as a community can support each other on our journeys and cope all together. So thank you very much for listening.
I think you'll agree that was really interesting hearing both sides. It's good. Thank you.